Endocrine embryology, thyroid development. All right, let's go over the embryology of the thyroid gland. The thyroid gland begins as a thyroid diverticulum. This diverticulum arises from the floor of the primitive pharynx and then descends down into the neck. While it descends, it remains connected to the tongue by a structure called the thyroglossal duct. Normally, this duct disappears, but sometimes it can persist. If it persists, it can form thyroglossal duct cysts or a pyramidal lobe of the thyroid. Now, the foramen cecum on the tongue is actually a normal remnant of this thyroglossal duct. So when you see that little pit at the back of the tongue, that's the developmental reminder of the thyroid's origin. The most common site for ectopic thyroid tissue is at the tongue itself, called a lingual thyroid. This is clinically important because if the lingual thyroid is the only functioning thyroid tissue, removing it could cause hypothyroidism. Now let's compare cysts that a thyroglossal duct cyst usually presents as a midline anterior neck mass. And importantly, it moves when the patient swallows or sticks out the tongue. This is different from a pharyngeal cleft cyst, which comes from a persistent cervical sinus. Those appear on the lateral side of the neck, not the midline. Next, let's look at the embryological origin of the thyroid cells. The thyroid follicular cells are derived from endoderm. On the other hand, the parafollicular cells, also called C cells, which secrete calcitonin, come from the fourth pharyngeal pouch. Finally, let's mention the anatomy and blood supply associated with the thyroid. Foramen cecum is the origin point at the tongue. As it descends, it passes near the hyoid bone, the thyrohyoid membrane, and the thyroid cartilage. The thyroid is supplied superiorly by the superior thyroid artery and inferiorly by the inferior thyroid artery, which comes from the thyrocervical trunk. It also has venous and arterial connections with the carotid arteries, the brachiocephalic artery, and the subclavian artery. Endocrine anatomy. Pituitary gland. The anterior pituitary, also called the adenohypophysis, secretes follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid-stimulating hormone, prolactin, growth hormone, and beta-endorphin. Melanotropin, also called MSH, is secreted from the intermediate lobe of the pituitary. The anterior pituitary is derived from oral ectoderm, specifically Rathke pouch. The alpha subunit is the common hormone subunit found in TSH, LH, FSH, and HCG. The beta subunit determines hormone specificity. Proopiomelanocortin, or POMC, gives rise to beta-endorphin, ACTH, and MSH. The mnemonic flat peg helps recall anterior pituitary hormones, FSH, LH, ACTH, TSH, prolactin, and growth hormone. B-flat indicates the basophils which secrete FSH, LH, ACTH, and TSH. Acid pig indicates the acidophils which secrete prolactin and growth hormone. The posterior pituitary, also called the neurohypophysis, stores and releases vasopressin, also known as antidiuretic hormone or ADH, and oxytocin. Both are produced in the hypothalamus, specifically in the supraoptic and paraventricular nuclei, and transported to the posterior pituitary via carrier proteins called neurophycins. The posterior pituitary is derived from neuroectoderm. Adrenal cortex and medulla. The adrenal cortex is derived from mesoderm. The adrenal medulla is derived from neural crest cells. The adrenal cortex has 3 layers. The zona glomerulosa is regulated by angiotensin II, produces mineralocorticoids, mainly aldosterone. The zona fasciculata is regulated by ACTH and CRH, produces glucocorticoids, mainly cortisol. The zona reticularis is regulated by ACTH and CRH, produces androgens, including DHEA. The adrenal medulla contains chromaffin cells, stimulated by preganglionic sympathetic fibers, and produces catecholamines, epinephrine and norepinephrine. The mnemonic GFR corresponds with salt, sugar, and sex. Glomerulosa for salt, fasciculata for sugar, reticularis for sex. Endocrine pancreas. The endocrine pancreas consists of the islets of Langerhans, which arise from pancreatic buds. They contain 3 main cell types. Alpha cells, located peripherally, secrete glucagon. Beta cells, located centrally, secrete insulin. Delta cells, scattered throughout, secrete somatostatin. For endocrine physiology, hypothalamic-pituitary hormones. Antidiuretic hormone, or ADH, increases water permeability of distal convoluted tubule and collecting duct cells in the kidney, leading to increased water reabsorption. Alcohol consumption decreases antidiuretic hormone secretion, leading to polyuria and dehydration. Corticotropin-releasing hormone, or CRH, increases adrenocorticotropic hormone, melanocyte-stimulating hormone, and beta-endorphin. Its secretion is decreased in chronic glucocorticoid use. Prolactin-inhibiting factor decreases prolactin and thyroid-stimulating hormone secretion. This factor is commonly referred to as dopamine. Dopamine antagonists, such as antipsychotics, can cause galactorrhea due to hyperprolactinemia. Growth hormone, releasing hormone, or GHRH, increases growth hormone secretion. An analog of GHRH, tesamorelin, is used to treat HIV-associated lipodystrophy. Gonadotropin-releasing hormone, or GnRH, increases follicle-stimulating hormone and luteinizing hormone. It is suppressed by hyperprolactinemia. Continuous administration of GnRH analogs, such as leuprolide, suppresses the hypothalamic-pituitary gonadal axis. Pulsatile GnRH secretion is required for puberty and fertility. Melanocyte-stimulating hormone, or MSH, increases melanogenesis by melanocytes. It causes hyperpigmentation in Cushing disease because MSH and ACTH share the same precursor molecule, propiamelanocortin. Oxytocin causes uterine contractions during labor and is responsible for the milk letdown reflex in response to suckling. It also modulates fear, anxiety, social bonding, mood, and depression. Prolactin decreases GnRH secretion. It stimulates lactogenesis. Pituitary prolactinoma can cause amenorrhea, osteoporosis, hypogonadism, and galactorrhea. During breastfeeding, prolactin decreases GnRH secretion, which delays postpartum ovulation and serves as a natural form of contraception. Somatostatin decreases growth hormone and thyroid-stimulating hormone. It is also called growth hormone, inhibiting hormone. Thyrotrophin-releasing hormone, or TRH, increases thyroid-stimulating hormone and prolactin. Increased TRH, as seen in primary or secondary hypothyroidism, may lead to increased prolactin secretion and galactorrhea. Growth hormone. Growth hormone is also called somatotropin. It is secreted by the anterior pituitary. Its main functions are to stimulate linear growth and muscle mass through secretion of insulin-like growth factor 1, also called somatomedin C, by the liver. Growth hormone also causes insulin resistance, making it diabetogenic. Growth hormone is released in pulses in response to growth hormone, releasing hormone, or GHRH. Secretion is increased during deep sleep, hypoglycemia, stress, puberty, and exercise. Secretion is decreased with aging, obesity, hyperglycemia, somatostatin, and somatomedin, which is the feedback regulatory molecule secreted by the liver in response to GH acting on target tissues. Excess growth hormone secretion, for example from a pituitary adenoma, may cause acromegaly in adults or gigantism in children. Treatment includes somatostatin analogs such as octreotide or surgery. Growth hormone increases amino acid uptake, protein synthesis, DNA and RNA synthesis, chondroitin sulfate, collagen, cell size, and cell number. Through IGF-1, it increases amino acid uptake, protein synthesis, glucose uptake, and lipolysis. Antidiuretic hormone, ADH. Antidiuretic hormone is also called vasopressin. Source: it is synthesized in the hypothalamus, specifically the supraoptic and paraventricular nuclei, and then stored and secreted by the posterior pituitary. Function: ADH regulates blood pressure through V1 receptors and serum osmolality through V2 receptors. Its primary function is regulation of serum osmolality. ADH decreases serum osmolality and increases urine osmolality by controlling insertion of aquaporin channels in the principal cells of the renal collecting duct. Clinical: ADH levels are decreased in central diabetes insipidus and normal or increased in nephrogenic diabetes insipidus. Desmopressin, an ADH analog, is used to treat central diabetes insipidus and nocturnal enuresis. Vasopressin is also a potent vasopressor and can be used to increase organ perfusion in septic shock. Regulation: the primary regulator of ADH is plasma osmolality. Hypovolemia also stimulates ADH release. Prolactin. Source: prolactin is secreted mainly by the anterior pituitary. Prolactin is structurally homologous to growth hormone. Function: it stimulates milk production in the breast. It also inhibits ovulation in females and spermatogenesis in males by inhibiting the synthesis and release of gonadotropin-releasing hormone, or GnRH. Excess prolactin may cause different symptoms in males and females. In females, excessive prolactin can cause galactorrhea, amenorrhea, infertility, and osteoporosis. In males, it can cause gynecomastia, infertility, decreased libido, and impotence. Regulation: prolactin secretion from the anterior pituitary is tonically inhibited by dopamine release from the tuberoinfundibular pathway of the hypothalamus. Prolactin, in turn, inhibits its own secretion by stimulating dopamine synthesis and release from the hypothalamus. Thyrotrophin-releasing hormone, or TRH, increases prolactin secretion, for example in primary or secondary hypothyroidism. Dopamine has a stronger inhibitory effect on prolactin secretion than TRH has in stimulating it. Treatment: dopamine agonists, such as bromocriptine or cabergoline, inhibit prolactin secretion and are used to treat prolactinomas. Dopamine antagonists, such as most antipsychotics and metoclopramide, increase prolactin secretion. Estrogens from oral contraceptives or pregnancy also stimulate prolactin secretion. Now let's move to thyroid hormone. The thyroid produces triiodothyronine, also called T3, and thyroxine, also called T4. These are iodine-containing hormones that control the body's metabolic rate. The source is the follicles of the thyroid gland. T4 is the major thyroid product. It is converted to T3 in peripheral tissue by the enzyme 5'-deiodinase. This peripheral conversion is inhibited by glucocorticoids, beta blockers, and propylthiouracil. Reverse T3, also called RT3, is a metabolically inactive byproduct of peripheral T4 conversion. Its production is increased by growth hormone and glucocorticoids. Thyroid peroxidase is the enzyme responsible for oxidation, organification of iodine, and coupling of monoiodotyrosine with diiodotyrosine. DIT plus DIT produces T4, while DIT plus MIT produces T3. Thyroid peroxidase is inhibited by propylthiouracil and methimazole. A protective autoregulation called the Wolff-Chaikoff effect occurs when sudden exposure to excess iodine temporarily turns off thyroid peroxidase and decreases T3 and T4 production. Only the free thyroid hormone is active. T3 binds to nuclear receptors with greater affinity than T4. The functions of T3 are summarized by the 7 Bs. Brain maturation. Bone growth, which acts synergistically with growth hormone and insulin-like growth factor 1. Beta-adrenergic effects through beta-1 receptors in the heart, which increase cardiac output, heart rate, stroke volume, and contractility. This is why beta blockers alleviate adrenergic symptoms in thyrotoxicosis. Basal metabolic rate increases via increased sodium, potassium ADPase activity, which raises oxygen consumption, respiratory rate, and body temperature. Blood sugar increases through glycogenolysis and gluconeogenesis. Breakdown of lipids increases through lipolysis. And finally, T3 stimulates surfactant synthesis in babies. Regulation occurs through thyrotrophin-releasing hormone, which stimulates thyroid-stimulating hormone release from the anterior pituitary. TSH then stimulates the thyroid follicular cells. Thyroid-stimulating immunoglobulin, seen in Graves' disease, can also stimulate follicular cells. Negative feedback is primarily exerted by free T3 and T4. They reduce the anterior pituitary sensitivity to thyrotrophin-releasing hormone and also reduce TRH secretion from the hypothalamus. Thyroxine-binding globulin, or TBG, binds most circulating T3 and T4 in the blood, and bound hormone is inactive. Thyroxine-binding globulin increases in pregnancy and in oral contraceptive use because estrogen raises TBG levels. Thyroxine-binding globulin decreases in steroid use and in nephrotic syndrome. T3 and T4 are unique because they are the only lipophilic hormones that contain charged amino acids, and they require specific transporters for facilitated diffusion into the cell. Parathyroid hormone is secreted by the chief cells of the parathyroid glands. Its primary function is to increase free calcium levels in the blood. It increases calcium and phosphate absorption from the gastrointestinal system. It increases calcium and phosphate release from bone resorption. It increases calcium reabsorption in the distal convoluted tubule. It decreases phosphate reabsorption in the proximal convoluted tubule. It also increases the production of 1,25-dihydroxyvitamin D, also called calcitriol, by activating 1-alpha hydroxylase in the proximal convoluted tubule. This helps to increase calcium absorption in the gut. The net effect of parathyroid hormone is increased serum calcium, decreased serum phosphate, increased urinary phosphate, and increased urinary cyclic AMP. Parathyroid hormone also stimulates rank ligand secretion by osteoblasts and osteocytes. Rank ligand binds to the rank receptor on osteoclasts and their precursors, stimulating osteoclast activity and thereby increasing calcium and bone resorption. Interestingly, intermittent release of parathyroid hormone can stimulate bone formation instead of resorption. A helpful memory aid is that parathyroid hormone is the phosphate-trashing hormone. Parathyroid hormone-related peptide, or PTHrP, functions in a manner similar to PTH. It is commonly increased in malignancies, such as squamous cell carcinoma of the lung and renal cell carcinoma. Regulation of PTH secretion depends on calcium, phosphate, and magnesium levels. Decreased serum calcium increases PTH secretion. Increased serum phosphate also increases PTH secretion. Magnesium has a dual effect. Mild decreases in serum magnesium increase PTH secretion. However, severe hypomagnesemia decreases PTH secretion. Common causes of low magnesium include diarrhea, aminoglycoside antibiotics, diuretics, and alcohol use disorder. There are 4 parathyroid glands, and calcium is the major regulator of PTH release. Calcium homeostasis. Plasma calcium exists in 3 forms. About 45% is ionized or free calcium, which is the active form. About 40% is bound to albumin. And about 15% is bound to anions. Ionized calcium is the primary regulator of parathyroid hormone. Changes in pH alter ionized calcium levels and therefore affect PTH secretion, while changes in albumin concentration do not. Now, let's look at the effect of pH. Calcium competes with hydrogen ions to bind albumin. In alkalemia, where there are fewer hydrogen ions, albumin binds more calcium. This decreases the level of ionized calcium in the blood, leading to symptoms such as cramps, pain, paresthesias, or carpopedal spasm. In acidemia, where there are more hydrogen ions, albumin binds less calcium. This increases ionized calcium in the blood and reduces parathyroid hormone secretion. Now, moving to calcitonin. Calcitonin is secreted by the parafollicular cells, also called C cells, of the thyroid gland. Calcitonin opposes the action of parathyroid hormone by inhibiting bone resorption. Although calcitonin is not essential in normal calcium homeostasis, its effect is to tone down serum calcium levels and keep calcium stored in bones. Its secretion is regulated by serum calcium. When calcium rises, calcitonin secretion increases. Next, glucagon. Glucagon is secreted by the alpha cells of the pancreas. Its function is to increase blood sugar levels to maintain homeostasis when bloodstream glucose levels fall too low during fasting states. It promotes glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. Glucagon secretion is stimulated by hypoglycemia. It is inhibited by insulin, amylin, somatostatin, and hyperglycemia. Insulin. Synthesis. Insulin is synthesized in the pancreatic beta cells. The process begins in the rough endoplasmic reticulum with pre-proinsulin. After cleavage of the pre-signal, proinsulin is formed and stored in secretory granules. Inside these granules, proinsulin is cleaved to produce insulin and C-peptide, which are released in equal amounts during exocytosis. Both insulin and C-peptide are markers of endogenous insulin secretion, as seen in type 2 diabetes mellitus, insulin secretagogues, or insulinoma. In contrast, exogenous insulin lacks C-peptide, and this helps differentiate factitious hypoglycemia from true endogenous secretion. Insulin is synthesized in the pancreas and cleared by both the liver and the kidneys. Function: insulin binds to its receptor, which has tyrosine kinase activity. This triggers glucose uptake through carrier-mediated transport in insulin-dependent tissues and also induces gene transcription. The anabolic effects of insulin include the following: increased glucose transport in skeletal muscle and adipose tissue, stimulation of glycogen synthesis and storage, stimulation of triglyceride synthesis, sodium retention by the kidneys, protein synthesis in muscle, cellular uptake of potassium and amino acids, decreased glucagon release, decreased lipolysis in adipose tissue. Unlike glucose, insulin itself does not cross the placenta. However, in mothers with diabetes, excess maternal glucose does cross the placenta, which stimulates increased fetal insulin secretion. Glucose transporters. Insulin-dependent glucose transport occurs mainly through GLUT4, found in adipose tissue and striated muscle. Exercise can also increase GLUT4 expression. Insulin-independent transporters include GLUT1, found in red blood cells, brain, cornea, and placenta. GLUT2, a bidirectional transporter present in beta cells, liver, kidney, and the gastrointestinal tract. Think of GLUT2 as a two-way street. GLUT3 is found in the brain and placenta. GLUT5 is used for fructose transport, present in spermatocytes and the GI tract. Sodium glucose cotransporters, SGLT1 and SGLT2, are located in the kidney and small intestine. The brain prefers glucose as its energy source, but during starvation, it can also use ketone bodies. Red blood cells utilize only glucose since they lack mitochondria for aerobic metabolism. Remember the mnemonic brick lips for insulin-dependent glucose uptake: brain, red blood cells, intestine, cornea, kidney, liver, islet beta cells, placenta, and spermatocytes. Regulation. Glucose is the major regulator of insulin release. Insulin response is greater after oral glucose compared to intravenous glucose. This is due to incretins, such as glucagon-like peptide 1, glucose-dependent insulinotropic polypeptide, which are released after meals and increase beta cell sensitivity to glucose. Insulin release is decreased by alpha-2 adrenergic stimulation and increased by beta-2 adrenergic stimulation. Remember, 2 regulates insulin. The mechanism of insulin release begins with glucose entering beta cells. Metabolism of glucose produces ADP, which closes potassium channels, the same channels targeted by sulfonylureas. Closure of these channels depolarizes the beta cell membrane, opening voltage-gated calcium channels. The resulting calcium influx triggers exocytosis of insulin. Adrenal steroids and congenital adrenal hyperplasias. Cholesterol, via cholesterol desmolase, is converted to pregnenolone. Pregnenolone, through 17-alpha hydroxylase, becomes 17-hydroxypregnenolone. 17-hydroxypregnenolone is converted to dehydroepiandrosterone, also called DHEA. Pregnenolone can also be converted by 3-beta-hydroxysteroid dehydrogenase into progesterone. Progesterone, via 17-alpha-hydroxylase, becomes 17-hydroxyprogesterone. 17-hydroxyprogesterone converts to androstenedione. Androstenedione can be converted to testosterone. Testosterone can be converted by 5-alpha reductase into dihydrotestosterone, also called DHT. It can also be converted by aromatase into estradiol. Androstenedione may also be converted by aromatase into estrone. Progesterone, via 21-hydroxylase, becomes 11-deoxycorticosterone. 11-deoxycorticosterone, via 11-beta-hydroxylase, becomes corticosterone. Corticosterone is converted by aldosterone synthase into aldosterone. This occurs under the effect of angiotensin II. Aldosterone is produced in the zona glomerulosa, which makes mineralocorticoids. 17-hydroxyprogesterone, via 21-hydroxylase, becomes 11-deoxycortisol. 11-deoxycortisol, via 11-beta-hydroxylase, becomes cortisol. Cortisol is produced in the zona fasciculata, which makes glucocorticoids. Cortisol can also be converted to cortisone by the action of glycyrrhetinic acid. Androstenedione, testosterone, and dihydroepiandrosterone are produced in the zona reticularis, which makes androgens. Peripheral tissues convert androgens to estrogens and dihydrotestosterone. At the bottom, the diagram shows the adrenal gland with capsule, cortex, and medulla. Now let's review the individual enzyme deficiencies. First, 17-alpha-hydroxylase deficiency. In mineralocorticoids, aldosterone decreases and 11-deoxycorticosterone levels are high. Potassium levels fall, leading to hypokalemia. Blood pressure increases, causing hypertension. Cortisol is low. Sex hormones are also low, with decreased androstenedione. Clinically, in males with XY chromosomes, there is atypical genitalia and undescended testes. In females with XX chromosomes, there is a lack of secondary sexual development. Second, 21-hydroxylase deficiency. This is the most common form. Mineralocorticoids are low, leading to salt wasting. Potassium levels rise, causing hyperkalemia. Blood pressure falls, leading to hypotension. Cortisol is low. Sex hormones are increased, causing high androgen levels. Laboratory findings include increased renin activity and elevated 17-hydroxyprogesterone. Clinically, this may present in infancy with vomiting, dehydration, and salt-wasting crisis, or in childhood with precocious puberty. Females with XX chromosomes show virilization. Third, 11-beta-hydroxylase deficiency. In mineralocorticoids, aldosterone are decreased and 11-deoxycorticosterone increased. Potassium is low, causing hypokalemia. Blood pressure is high, leading to hypertension. Cortisol is low. Sex hormones are increased. Laboratory findings show decreased renin activity. Clinically, this can present in infancy with severe hypertension or in childhood with precocious puberty. Females with XX chromosomes show virilization. Key points to remember. All congenital adrenal enzyme deficiencies are autosomal recessive disorders. Most are characterized by skin hyperpigmentation due to increased melanocyte-stimulating hormone production, which is co-secreted with ACTH. They are also associated with bilateral adrenal gland enlargement due to chronic ACTH stimulation. Results in increased BP. A useful rule is this. If the deficient enzyme starts with a 1, it causes hypertension. If the deficient enzyme ends with a 1, it causes virilization in females. Cortisol. Cortisol is produced in the adrenal zona fasciculata. In the bloodstream, it circulates bound to corticosteroid-binding globulin. Functions of cortisol can be remembered by the phrase cortisol is a big fib. A stands for increased appetite. B stands for increased blood pressure. I stand for increased insulin. G stands for increased gluconeogenesis. F stands for decreased fibroblast activity. I stands for decreased inflammatory and immune responses. B stands for decreased bone formation. Increased blood pressure. Cortisol upregulates alpha-1 receptors on arterioles, which increases their sensitivity to norepinephrine and epinephrine. This is a permissive action at very high concentrations. Cortisol can also bind to mineralocorticoid or aldosterone receptors. Increased insulin resistance. This is why cortisol is considered diabetogenic. Increased gluconeogenesis, lipolysis, and proteolysis, which all decrease glucose utilization. Decreased fibroblast activity, which leads to poor wound healing, reduced collagen synthesis, and striae. Decreased inflammatory and immune responses. Cortisol inhibits leukotriene and prostaglandin production. It reduces white blood cell adhesion, leading to neutrophilia. It blocks histamine release from mast cells, causes eosinopenia and lymphopenia, and blocks interleukin-2 production. Because of this, exogenous glucocorticoids can cause reactivation of tuberculosis or candidiasis. Decreased bone formation due to inhibition of osteoblast activity. Regulation of cortisol. The hypothalamus releases corticotropin-releasing hormone, or CRH, which stimulates the anterior pituitary to release ACTH. ACTH then stimulates cortisol production in the adrenal zona fasciculata. Excess cortisol provides negative feedback, inhibiting both CRH and ACTH release. Chronic stress can lead to prolonged cortisol secretion, cortisol resistance, impaired immune competency, and dysregulation of the hypothalamic-pituitary adrenal axis. Appetite regulation. Several hormones regulate appetite. Ghrelin is produced by the stomach. It stimulates hunger, also known as an orexigenic effect, and stimulates growth hormone release via the growth hormone secretagogue receptor. Ghrelin levels increase with sleep deprivation, fasting, and in Prader-Willi syndrome. You can remember this by the phrase, ghrelin makes you grow hungry. Ghrelin acts on the lateral hypothalamus, which is the hunger center, to increase appetite. Leptin is the satiety hormone produced by adipose tissue. Mutation of the leptin gene can cause severe obesity. Obese individuals often have elevated leptin due to increased adipose tissue, but are resistant to leptin's anorexogenous effects. Sleep deprivation and starvation reduce leptin production. You can remember, leptin keeps you thin. It acts on the ventromedial hypothalamus, which is the satiety center, to decrease appetite. Endocannabinoids act on cannabinoid receptors in the hypothalamus and nucleus accumbens, which are key brain areas for the homeostatic and hedonic control of food intake. They increase appetite. This explains why exogenous cannabinoids, such as marijuana, cause the munchies. Signaling pathways of endocrine hormones. Some hormones use the cyclic adenosine monophosphate pathway, also called the CAMP pathway. These include follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid-stimulating hormone, corticotropin-releasing hormone, human chorionic gonadotropin, antidiuretic hormone acting on the V2 receptor, melanocyte-stimulating hormone, parathyroid hormone, calcitonin, histamine acting on the H2 receptor, glucagon, and growth hormone, releasing hormone. You can remember them with a mnemonic flat champs chug. Other hormones use the cyclic guanosine monophosphate pathway, also called the cGMP pathway. These include brain natriuretic peptide, atrial natriuretic peptide, and nitric oxide, which is also called endothelial-derived relaxing factor. These hormones are associated with vasodilation and diuresis, meaning increased urine production. You can remember this with bad grandpa. Another group of hormones uses the inositol triphosphate pathway, also called the IP3 pathway. These include gonadotropin-releasing hormone, oxytocin, antidiuretic hormone acting on the V1 receptor, thyrotrophin-releasing hormone, histamine acting on the H1 receptor, angiotensin II, and gastrin. The mnemonic is GOAT-HAG. Some hormones act directly through intracellular receptors because they are lipophilic. These include progesterone, estrogen, testosterone, cortisol, aldosterone, triiodothyronine, which is also called T3, thyroxine, which is also called T4, and vitamin D. You can remember this with the mnemonic pet cat in TV. Another group of hormones acts through receptor tyrosine kinases, which signal by using the mitogen-activated protein kinase pathway, also known as the MAP kinase pathway. These include insulin-like growth factor 1, fibroblast growth factor, platelet-derived growth factor, epidermal growth factor, and insulin. You can remember this with get found in the MAP. Some hormones use non-receptor tyrosine kinases. These act through the Janus kinase and signal transducer and activator of transcription pathway, also called the JAK-STAT pathway. These include granulocyte colony stimulating factor, erythropoietin, thrombopin, prolactin, immunomodulators such as interleukin-2, interleukin-6, and interferons, as well as growth hormone. Here, think acidophils and cytokines. You can remember this with get a Jake pig. Signaling pathways of steroid hormones. Steroid hormones are lipophilic, meaning they dissolve in fat. Because of this property, they must circulate in the blood bound to specific binding globulins, which increase their solubility. In males, increased sex hormone binding globulin lowers the level of free testosterone, and this can cause breast enlargement, also known as gynecomastia. In females, decreases sex hormone binding globulin raises the level of free testosterone, and this can cause excessive hair growth, also called hirsutism. Increased estrogen, such as during pregnancy or when taking oral contraceptive pills, increases the level of sex hormone binding globulin. Endocrine pathology. Syndrome of inappropriate antidiuretic hormone secretion. Syndrome of inappropriate antidiuretic hormone secretion is characterized by excessive free water retention. The patient develops low sodium in the blood, which is called hyponatremia, but their overall fluid volume remains normal, a state called euvolemia. This occurs with continued urinary sodium excretion, and the urine osmolality is higher than the serum osmolality. The body responds to water retention by decreasing aldosterone secretion and by increasing atrial natriuretic peptide and brain natriuretic peptide. This increases urinary sodium secretion and normalizes the extracellular fluid volume. However, the result is still a euvolemic hyponatremia. Treatment begins with fluid restriction, which is the first-line therapy. Other options include salt tablets, intravenous hypertonic saline, diuretics or antagonists of antidiuretic hormone, such as conivaptan, tolvaptan, or dimeclocycline. Causes of syndrome of inappropriate antidiuretic hormone secretion include head trauma or central nervous system disorders. Ectopic secretion of antidiuretic hormone, such as from small cell lung cancer, exogenous hormone use such as vasopressin, desmopressin, or oxytocin, lung disease, and several drugs including selective serotonin reuptake inhibitors, carbamazepine, and cyclophosphamide. Primary polydipsia and diabetes insipidus. These conditions are characterized by the production of large amounts of dilute urine, sometimes with excessive thirst. Urine-specific gravity is less than 1.006, and urine osmolality is usually less than 300 milliosmoles per kilogram. Central diabetes insipidus may be transient if the damage is below the hypothalamic median eminence or in the posterior pituitary, because antidiuretic hormone made in the hypothalamus can still be secreted into the systemic circulation through the portal capillaries of the median eminence. Central diabetes insipidus is also known as arginine vasopressin deficiency. Nephrogenic diabetes insipidus is also known as arginine vasopressin resistance. Definitions. Primary polydipsia is defined as excessive water intake. Central diabetes insipidus is defined as decreased release of antidiuretic hormone. Nephrogenic diabetes insipidus is defined as resistance to antidiuretic hormone. Causes. Primary polydipsia can be caused by psychiatric illness or hypothalamic lesions that affect the thirst center. Central diabetes insipidus can be idiopathic, or it can result from brain injury due to trauma, hypoxia, tumors, surgery, or infiltrated diseases. Nephrogenic diabetes insipidus may be hereditary, for example, due to a mutation of the vasopressin receptor 2, or it may be acquired. Acquired causes include drugs such as lithium or dimeclocycline, as well as electrolyte disturbances such as high calcium or low potassium. Laboratory findings. In primary polydipsia, serum osmolality is decreased and antidiuretic hormone levels are decreased or normal. In central diabetes insipidus, serum osmolality is elevated and antidiuretic hormone levels are decreased. In nephrogenic diabetes insipidus, serum osmolality is elevated and antidiuretic hormone levels are normal or increased. Water restriction test. In primary polydipsia, water restriction leads to a significant increase in urine osmolality, usually greater than 700 milliosmoles per kilogram. In central diabetes insipidus, there is no significant change or only a slight increase in urine osmolality. In nephrogenic diabetes insipidus, there is also no significant change or only a slight increase in urine osmolality. Desmopressin administration. Desmopressin is a synthetic analog of antidiuretic hormone. In central diabetes insipidus, administration of desmopressin causes a significant rise in urine osmolality, typically greater than 50%. In nephrogenic diabetes insipidus, there is minimal change in urine osmolality. Treatment. Primary polydipsia is managed with water restriction. Central diabetes insipidus is treated with desmopressin, also known as DDAVP. Nephrogenic diabetes insipidus is treated by managing the underlying cause, using a low-solute diet, and with medications such as hydrochlorothiazide, amiloride, or indomethacin. Note on the water deprivation test. In this test, the patient has no water intake for 2 to 3 hours, followed by hourly measurements of urine volume and urine osmolality, as well as plasma sodium concentration and plasma osmolality. Desmopressin is administered if the serum osmolality is greater than 295 to 300 milliosmoles per kilogram. Plasma sodium is greater than or equal to 145 milliequivalents per liter, or if urine osmolality does not increase despite a rising plasma osmolality. Hypopituitarism. Hypopituitarism refers to the undersecretion of pituitary hormones. This can occur due to several causes. It may result from hypothalamic disease, such as mass lesions, radiation, or infiltrative lesions. It may also follow pituitary surgery. Other causes include pituitary disorders, such as mass effect from a non-secreting pituitary adenoma or from craniopharyngioma. An empty sella can also lead to hypopituitarism. A specific cause is Sheehan syndrome, which is an ischemic infarction of the pituitary gland following severe postpartum hemorrhage. During pregnancy, the pituitary enlarges, making it more susceptible to low blood flow. Sheehan syndrome usually presents with failure to lactate, absence of menstrual periods, and cold intolerance, as the anterior pituitary hormones are mainly affected. The treatment for hypopituitarism is hormone replacement therapy. This includes glucocorticoids, thyroxine, sex steroids, and human growth hormone. Acromegaly. Acromegaly is caused by excess secretion of growth hormone in adults. The most common cause is a pituitary adenoma. The findings in acromegaly include a large tongue with deep furrows, frontal bossing, and coarsening of facial features with aging. The patient may develop a deep voice, excessive sweating, hypertrophic joint disease, and impaired glucose tolerance due to insulin resistance. High blood pressure is common, and the heart may develop left ventricular hypertrophy and heart failure with preserved ejection fraction, which is the most common cause of death in these patients. In children, excess growth hormone causes gigantism, characterized by excessive linear bone growth due to unfused growth plates, also called epiphyses. Thus, acromegaly occurs in adults, and gigantism occurs in children. Diagnosis of acromegaly begins with measuring serum insulin-like growth factor 1, because growth hormone levels fluctuate throughout the day and are therefore unreliable. Another diagnostic method is the oral glucose tolerance test. Normally, glucose suppresses growth hormone levels, but in acromegaly, growth hormone fails to suppress. Imaging with brain magnetic resonance imaging may reveal a pituitary mass. Treatment begins with surgical resection of the pituitary adenoma. If surgery does not cure the condition, medical therapy can be used. Options include octreotide, which is a somatostatin analog, pegvisomant, which is a growth hormone receptor antagonist, or dopamine agonists such as cabergoline. Hypothyroidism versus hyperthyroidism. Metabolic features. In hypothyroidism, there is cold intolerance, decreased sweating, and weight gain. This occurs because of a decreased basal metabolic rate and decreased heat production, also called calorigenesis. Hyponatremia may occur due to impaired clearance of free water. In hyperthyroidism, there is heat intolerance, increased sweating, and weight loss. This happens because thyroid hormone increases the activity of sodium, potassium adenosine triphosphatase, which raises the basal metabolic rate and calorigenesis. Skin and hair changes. In hypothyroidism, the skin is dry and cool due to reduced blood flow. The hair is coarse and brittle, and there may be diffuse alopecia. Nails become brittle. The face appears puffy, with generalized non-pitting edema called myxedema. This is caused by increased glycosaminoglycans in the interstitial spaces, which raise osmotic pressure and lead to water retention. In hyperthyroidism, the skin is warm and moist due to vasodilation. The hair is fine and thin. Onycholysis, which is separation of the nail from the nail bed, may occur. In Graves' disease, pretibial myxedema is seen. Ocular findings. In hypothyroidism, periorbital edema may be present. In hyperthyroidism, particularly Graves' disease, there is ophthalmopathy. This includes periorbital edema, protrusion of the eyeball called exophthalmos, and lid lag or lid retraction due to increased sympathetic stimulation of the superior tarsal muscle. Gastrointestinal features. In hypothyroidism, constipation occurs because of reduced gastrointestinal motility and appetite is decreased. In hyperthyroidism, hyperdification or diarrhea occurs because of increased gastrointestinal motility and appetite is increased. Musculoskeletal features. In hypothyroidism, patients may develop hypothyroid myopathy, which is proximal muscle weakness with elevated creatine kinase levels. Carpal tunnel syndrome may occur. Myoedema, which is a small lump rising on the surface of a muscle when struck with a hammer, may also be seen. In hyperthyroidism, patients may develop thyrotoxic myopathy, which is proximal muscle weakness with normal creatine kinase levels. They are also at risk of osteoporosis and increased fracture rate. This is because triiodothyronine, or T3, stimulates osteoclast differentiation, leading to increased bone resorption and calcium release. It may also affect osteoblasts. Reproductive features. In hypothyroidism, there may be abnormal uterine bleeding, decreased libido, and infertility. In hyperthyroidism, there may also be abnormal uterine bleeding, decreased libido, infertility, and sometimes gynecomastia. Neuropsychiatric features. In hypothyroidism, there is hypoactivity, lethargy, fatigue, weakness, depressed mood, and decreased reflexes. Reflexes are characteristically delayed or slow in relaxation phase. In hyperthyroidism, there is hyperactivity, restlessness, anxiety, insomnia, and fine tremors due to beta-adrenergic activity. Reflexes are brisk. Cardiovascular features. In hypothyroidism, patients may develop bradycardia and shortness of breath on exertion due to decreased cardiac output. In hyperthyroidism, patients develop tachycardia, palpitations, dyspnea, and arrhythmias such as atrial fibrillation. Chest pain and systolic hypertension may occur. These changes are due to an increased number and sensitivity of beta-adrenergic receptors, as well as increased expression of cardiac sarcolemmal adenosine triphosphatase and increased expression of phospholambin. Laboratory findings. In primary hypothyroidism, thyroid-stimulating hormone is increased, while free thyroxine, or T4, is decreased. There is hypercholesterolemia due to decreased expression of low-density lipoprotein receptors. In primary hyperthyroidism, thyroid-stimulating hormone is decreased, while free triiodothyronine, or T3, and thyroxine, or T4, are increased. Cholesterol levels, including low-density lipoprotein, high-density lipoprotein, and total cholesterol, are decreased. Hypothyroidism. Hashimoto thyroiditis, also called chronic autoimmune thyroiditis. It is the most common cause of hypothyroidism in regions where iodine intake is sufficient. It is associated with the human leukocyte antigen type DR3, although this association can vary by ethnicity. There is also an increased risk of developing primary thyroid lymphoma, most commonly diffuse large B-cell lymphoma. The thyroid gland is usually moderately enlarged and non-tender. Sometimes it is preceded by a transient hyperthyroid state, called hashitoxicosis, which happens because thyroid follicles rupture and release stored thyroid hormone. Serology findings include positive antithyroid peroxidase antibodies, also known as antimicrosomal antibodies, and positive antithyroglobulin antibodies. Histology findings include Hürthle cells, which are enlarged epithelial cells with abundant granular cytoplasm, as well as lymphoid aggregates with germinal centers. Postpartum thyroiditis. This is a mild, self-limited variant of Hashimoto thyroiditis that arises within 1 year after delivery. The natural course usually progresses through 3 phases. First, hyperthyroidism within the first 3 months after birth. Then hypothyroidism. And finally, recovery to a normal thyroid state, also called euthyroidism. Subacute granulomatous thyroiditis, also called a core vein thyroiditis. This is usually a self-limited disease. The natural course often progresses through 4 stages. First, transient hyperthyroidism. Then a normal thyroid state. Then hypothyroidism. And finally, a return to the normal thyroid state. It is often preceded by a viral infection. Findings include elevated erythrocyte sedimentation rate, jaw pain, and a very tender thyroid. A helpful way to remember this is the core vein is associated with pain. Histology shows granulomatous inflammation. Renal thyroiditis, also called invasive fibrous thyroiditis. This condition may occur as part of the immunoglobulin G4 related disease spectrum, which includes autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. Hypothyroidism occurs in about 1/3 of patients. Fibrosis may extend to local structures such as the trachea or esophagus, which can mimic anaplastic thyroid carcinoma. Findings include a slowly enlarging, very hard, rock-like, fixed and non-tender thyroid. Histology shows the thyroid gland replaced by fibrous tissue with an associated inflammatory infiltrate. Congenital hypothyroidism. This condition was formerly called cretinism. The most common cause in iodine-sufficient regions is thyroid dysgenesis, which means abnormal thyroid gland development, such as agenesis, hypoplasia, or ectopic thyroid tissue. Another cause is dishormonogenesis, which means abnormal thyroid hormone synthesis, often due to mutations in thyroid peroxidase. The classic findings can be remembered with the 6 Ps. a pot-bellied child, pale appearance, puffy face, a protruding umbilicus, a protuberant tongue, and poor brain development. Other causes of hypothyroidism. Worldwide, the most common cause is iodine deficiency. This usually presents with a goiter. Other causes include iodine excess, also known as the Wolff-Chaikoff effect, and certain drugs such as amiodarone or lithium. Non-thyroidal illness syndrome, also called euthyroid sick syndrome, is another cause. In this condition, there is low triiodothyronine, or T3, with normal or low thyroxine, or T4, and normal or low thyroid stimulating hormone. It is typically seen in critically ill patients. Hyperthyroidism. Graves' disease is the most common cause of hyperthyroidism. Thyroid-stimulating immunoglobulin, which is immunoglobulin G, can cause transient neonatal hyperthyroidism. It is a type 2 hypersensitivity reaction. Thyroid-stimulating immunoglobulin stimulates thyroid-stimulating hormone receptors on the thyroid gland, causing hyperthyroidism and diffuse goiter. It also stimulates dermal fibroblasts, causing pretibial myxedema, and orbital fibroblasts, causing Graves' orbitopathy. Treatment of Graves' orbitopathy is with glucocorticoids. Activation of T lymphocytes leads to lymphocytic infiltration of the retroorbital space, which increases cytokines including tumor necrosis factor alpha and interferon gamma. This increases fibroblast secretion of hydrophilic glycosaminoglycans, which causes osmotic swelling of muscles, muscle inflammation, and adipocyte enlargement. This process causes exophthalmos. Graves' disease often presents during stress, such as pregnancy. It is associated with human leukocyte antigen DR3 and human leukocyte antigen B8. Histology shows tall, crowded follicular epithelial cells and scalloped colloid. Toxic multinodular goiter consists of focal patches of hyperfunctioning follicular cells distended with colloid working independently of thyroid-stimulating hormone, due to thyroid-stimulating hormone receptor mutations in 60% of cases. This leads to release of triiodothyronine, also called T3, and thyroxine, also called T4. Hot nodules, meaning hyperfunctioning nodules, are visualized on radioactive iodine scan and are rarely malignant. Thyroid storm is an uncommon but serious complication that occurs when hyperthyroidism is incompletely treated or untreated and then significantly worsens in the setting of acute stress, such as infection, trauma, or surgery. It presents with agitation, delirium, fever, diarrhea, coma, and tachyarrhythmia, which is the cause of death. Liver function tests may be abnormal. Treatment is with the 4PS, beta blockers such as propranolol, propylthiouracil, glucocorticoids such as prednisolone, and potassium iodide, also called Lugol iodine. Iodide load decreases thyroxine synthesis through the Wolff-Chaikoff effect. Other causes of hyperthyroidism include exogenous thyrotoxicosis from excessive intake of thyroid hormone, suspect in patient trying to lose weight, ectopic thyroid production such as struma ovarii, contrast-induced thyroiditis also called JOD, Basedow phenomenon, and drug-induced thyroiditis from amiodarone or lithium. Causes of goiter include smooth or diffuse goiter, which is seen in Graves' disease, Hashimoto thyroiditis, iodine deficiency, and thyroid-stimulating hormone, secreting pituitary adenoma. Nodular goiter is seen in toxic multinodular goiter, thyroid adenoma, thyroid cancer, and thyroid cyst. Thyroid adenoma is a benign solitary growth of the thyroid. Most are non-functional and appear as cold nodules on radioactive iodine scan. Rarely, they can cause hyperthyroidism via autonomous thyroid hormone production, in which case they are hot or toxic nodules. The most common histology is follicular adenoma. Absence of capsular or vascular invasion distinguishes adenoma from follicular carcinoma. Thyroid cancer. Thyroid cancer is typically diagnosed with fine needle aspiration and treated with thyroidectomy. Complications of surgery include hypocalcemia due to removal of the parathyroid glands, transection of the recurrent laryngeal nerve during ligation of the inferior thyroid artery, leading to dysphagia and dysphonia, which is hoarseness, and injury to the external branch of the superior laryngeal nerve during ligation of the superior thyroid vascular pedicle, which may lead to loss of tenor, usually noticeable in professional voice users. Papillary carcinoma is the most common thyroid cancer. It shows empty-appearing nuclei with central clearing, also called orphan Annie eyes, psammoma bodies, and nuclear grooves. The mnemonic to remember Poppy and MoMA adopted orphan Annie. Risk is increased with RET and PTC rearrangements, BRAF mutations, and childhood irradiation. Papillary carcinoma is the most prevalent, often presents with palpable lymph nodes, and has a good prognosis. Follicular carcinoma has a good prognosis. It invades the tumor capsule and vasculature, unlike follicular adenoma. It shows uniform follicles. Hematogenic spread is common. It is associated with RES mutation and PX8, peroxisome proliferator activated receptor gamma translocations. Fine needle aspiration cytology may not be able to distinguish between follicular adenoma and follicular carcinoma. Medullary carcinoma arises from parafollicular C cells and produces calcitonin. It is composed of sheets of polygonal cells in an amyloid stroma, which stains with Congo red. It is associated with multiple endocrine neoplasia type 2A and type 2B due to RET mutations. Undifferentiated or anaplastic carcinoma occurs in older patients. It presents with a rapidly enlarging neck mass with compressive symptoms such as dyspnea, dysphagia, and hoarseness. It has a very poor prognosis. It is typically composed of pleomorphic cells with frequent mitoses. It may arise de novo, but most often arises from dedifferentiation of a pre-existing follicular carcinoma or papillary carcinoma. Diagnosing parathyroid disease. The graph plots parathyroid hormone levels on the vertical axis in picograms per milliliter against calcium levels on the horizontal axis in milligrams per deciliter. In primary hyperparathyroidism, which may be due to hyperplasia, adenoma, or carcinoma, calcium levels are elevated and parathyroid hormone levels are elevated. In secondary hyperparathyroidism, which is seen in vitamin D deficiency, decreased calcium intake, or chronic kidney disease, calcium levels are low and parathyroid hormone levels are high. In tertiary hyperparathyroidism, often occurring in chronic kidney disease, calcium levels are high and parathyroid hormone levels are very high. In hypoparathyroidism, usually due to surgical resection, autoimmune destruction, or injury to the parathyroid glands or their blood supply, calcium levels are low and parathyroid hormone levels are low. In parathyroid hormone, independent hypercalcemia, which can occur with excess calcium intake, cancer, or increased vitamin D, calcium levels are high and parathyroid hormone levels are low. Hypoparathyroidism may result from surgical resection, autoimmune destruction, or injury to the parathyroid glands or their blood supply, usually during thyroid surgery. It can also be associated with DiGeorge syndrome. Findings include tetany, hypocalcemia, and hyperphosphatemia. Chvostek sign is elicited by tapping the facial nerve, which leads to contraction of the facial muscles. Trousseau sign is seen when occlusion of the brachial artery with a blood pressure cuff produces carpal spasm. Pseudohyperthyroidism type 1A is an autosomal dominant condition transmitted maternally due to mutations in the imprinted GNAS gene. The GNAS1 inactivating mutation, which is coupled to the parathyroid hormone receptor, encodes the GS protein alpha subunit. This mutation leads to inactivation of adenylate cyclase when parathyroid hormone binds to its receptor, causing end-organ resistance in the kidney and bone to parathyroid hormone. Physical findings include Albright hereditary osteodystrophy, which is characterized by shortened fourth and fifth digits, short stature, round face, subcutaneous calcifications, and developmental delay. Laboratory results show elevated parathyroid hormone, decreased calcium, and increased phosphate. Pseudohypoparathyroidism is an autosomal dominant condition transmitted paternally due to mutations in the imprinted GNAS gene. However, in this case, there is no end-organ resistance to parathyroid hormone because the normal maternal allele maintains renal responsiveness to parathyroid hormone. Physical findings are the same as in Albright hereditary osteodystrophy. Laboratory values are normal, including parathyroid hormone, calcium, and phosphate. Laboratory values in hypocalcemic disorders. In vitamin D deficiency, calcium is normal or decreased, phosphate is normal or decreased, parathyroid hormone is increased, alkaline phosphatase is increased, 25-hydroxyvitamin D is decreased, and 1,25-dihydroxyvitamin D is normal or decreased. In secondary hyperparathyroidism, due to chronic kidney disease, calcium is decreased, phosphate is increased, parathyroid hormone is increased, alkaline phosphatase is increased, 25-hydroxyvitamin D is normal, and 1,25-dihydroxyvitamin D is decreased. In hypoparathyroidism, calcium is decreased, phosphate is increased, parathyroid hormone is decreased, and alkaline phosphatase is normal. 25-hydroxyvitamin D is normal, and 1,25-dihydroxyvitamin D is normal or decreased. In pseudohyperthyroidism, calcium is decreased, phosphate is increased, parathyroid hormone is increased, and alkaline phosphatase is increased. 25-hydroxyvitamin D is normal, and 1,25-dihydroxyvitamin D is normal or decreased. Hyperparathyroidism. Primary hyperparathyroidism, usually due to parathyroid adenoma or parathyroid hyperplasia. Findings include hypercalcemia, hypercalciuria also known as renal stones, polyuria also called thrones, hypophosphatemia, elevated parathyroid hormone, elevated alkaline phosphatase, and elevated urinary cyclic adenosine monophosphate. Most often patients are asymptomatic. Some may present with bone pain, weakness, and constipation, which are remembered as groans, abdominal or flank pain, such as kidney stones or acute pancreatitis, and neuropsychiatric disturbances, remembered as psychiatric overtones. Osteitis fibrosis cystica is seen. This consists of cystic bone spaces filled with brown fibrous tissue, also known as brown tumors, which consist of osteoclasts and hemosiderin deposited from hemorrhages. This causes bone pain. Osteitis fibrosis cystica is due to increased parathyroid hormone and is classically associated with primary hyperparathyroidism, but can also be seen in secondary hyperparathyroidism. This presentation is summarized as stones, thrones, bones, groans, and psychiatric overtones. Secondary hyperparathyroidism. This is parathyroid gland hyperplasia due to decreased calcium absorption and increased phosphate, most often seen in chronic kidney disease. Chronic kidney disease causes decreased vitamin D and hyperphosphatemia, leading to decreased calcium. Findings include hypocalcemia, hyperphosphatemia, and chronic kidney disease, which is different from hypophosphatemia seen in most other causes, and elevated alkaline phosphatase, with elevated parathyroid hormone. Tertiary hyperparathyroidism. This is refractory or autonomous hyperparathyroidism resulting from end-stage renal disease. Findings include elevated parathyroid hormone and elevated calcium. Renal osteodystrophy occurs in renal disease. It is due to secondary and tertiary hyperparathyroidism leading to bone lesions. Familial hypocalciuric hypercalcemia. This is an autosomal dominant condition due to defective G-protein-coupled calcium-sensing receptors in multiple tissues, such as the parathyroid glands and kidneys. Higher than normal calcium levels are required to suppress parathyroid hormone. Excessive renal calcium reabsorption leads to mild hypercalcemia and hypocalciuria with normal to elevated parathyroid hormone levels. Diabetes mellitus. Acute manifestations. The three classic Ps are polydipsia, polyuria, and polyphagia. Other findings include weight loss, diabetic ketoacidosis in type 1 diabetes, and hyperosmolar hyperglycemic state in type 2 diabetes. Rarely, diabetes mellitus can be caused by unopposed secretion of growth hormone and epinephrine. It is also seen in patients on glucocorticoid therapy, known as steroid diabetes. Chronic complications. Non-enzymatic glycation. Small vessel disease, also called hyaline arteriolosclerosis, causes retinopathy, neuropathy, and nephropathy. Large vessel disease, caused by atherosclerosis, leads to coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Myocardial infarction is the most common cause of death in patients with diabetes mellitus. Osmotic damage. This occurs due to sorbitol accumulation in organs that contain aldose reductase and either low or absent sorbitol dehydrogenase. Complications include neuropathy, such as motor neuropathy, sensory neuropathy in a glove and stocking distribution, and autonomic degeneration, which can manifest as gastroesophageal reflux disease, gastroparesis, or diabetic diarrhea. Other complications include cataracts. Diagnosis. Hemoglobin A1C of greater than or equal to 6.5%. This reflects average blood glucose over the prior 3 months and is influenced by red blood cell turnover. Fasting plasma glucose greater than or equal to 126 milligrams per deciliter after fasting for more than 8 hours. 2-hour oral glucose tolerance test greater than or equal to 200 milligrams per deciliter, measured 2 hours after consumption of 75 grams of glucose in water. Random plasma glucose greater than or equal to 200 milligrams per deciliter in the presence of hyperglycemic symptoms. When there is decreased available insulin, several metabolic changes occur. First, lipolysis increases, which raises plasma free fatty acid levels. This leads to increased ketogenesis, ketonemia, and ketonuria. As a result, an anion gap metabolic acidosis develops. Patients may present with vomiting, hyperventilation, and Kussmaul respiration. Second, proteolysis increases, which causes loss of muscle mass and weight loss. Third, gluconeogenesis increases and glycogenolysis also increases, along with decreased tissue glucose uptake, These processes lead to hyperglycemia and glycosuria. Hyperglycemia and glycosuria then cause osmotic diuresis, which results in the loss of water, sodium, and potassium. This leads to hypovolemia, which progresses to circulation failure and decreased tissue perfusion. At the same time, hyperglycemia increases plasma osmolality, which stimulates thirst. Type 1 diabetes mellitus and type 2 diabetes mellitus differ in many important ways. In type 1 diabetes mellitus, the primary defect is autoimmune T-cell mediated destruction of beta cells. In this condition, antibodies such as islet cell cytoplasmic antibodies, anti-glutamic acid decarboxylase antibodies, and insulin autoantibodies are often present. In type 2 diabetes mellitus, the defect is resistance to insulin with progressive pancreatic beta cell failure. In treatment, insulin is always necessary in type 1 diabetes mellitus, whereas it is only sometimes necessary in type 2 diabetes mellitus. The usual age of onset is younger than 30 years for type 1 diabetes mellitus and older than 40 years for type 2 diabetes mellitus. Obesity is not associated with type 1 diabetes mellitus, but it is commonly associated with type 2 diabetes mellitus. The genetic predisposition in type 1 diabetes mellitus is relatively weak, with about 50% concordance in identical twins, and it is polygenic. In contrast, type 2 diabetes mellitus has a relatively strong genetic predisposition, with about 90% concordance in identical twins, and it is also polygenic. There is an association with the human leukocyte antigen system in type 1 diabetes mellitus, specifically human leukocyte antigen DR4 and human leukocyte antigen DR3. Type 2 diabetes mellitus has no such association. Glucose intolerance in type 1 diabetes mellitus is severe, while in type 2 diabetes mellitus it is mild to moderate. Insulin sensitivity is high in type 1 diabetes mellitus and low in type 2 diabetes mellitus. Ketoacidosis is common in type 1 diabetes mellitus, but rare in type 2 diabetes mellitus. Beta cell numbers in the islets are variable in type 1 diabetes mellitus, whereas in type 2 diabetes mellitus, their amyloid deposits and beta cell numbers decline in advanced disease. Serum insulin levels are low in type 1 diabetes mellitus, while in type 2 diabetes mellitus, they may be increased initially but become decreased in advanced disease. The classic symptoms, which are polydipsia, polyuria, polyphagia, and weight loss, are commonly present in type 1 diabetes mellitus and are sometimes present in type 2 diabetes mellitus. Histology in type 1 diabetes mellitus shows an islet leukocytic infiltrate, whereas histology in type 2 diabetes mellitus shows islet amyloid polypeptide deposits. Now, let us look at hyperglycemic emergencies. The first is diabetic ketoacidosis. The pathogenesis involves insulin noncompliance or increased requirements due to stress, such as an infection. This leads to increased lipolysis and oxidation of free fatty acids, producing ketone bodies, with beta-hydroxybutyrate being greater than acetoacetate. In diabetic ketoacidosis, insulin is deficient and ketones are present. The second condition is hyperosmolar hyperglycemic state. The pathogenesis involves profound hyperglycemia, which causes excessive osmotic diuresis, dehydration, and increased serum osmolality. This condition is classically seen in older patients with type 2 diabetes mellitus who have a limited ability to drink. In hyperosmolar hyperglycemic state, insulin is present but ketones are deficient. The signs and symptoms of diabetic ketoacidosis can be remembered with the phrase, DKA is deadly. The letter D stands for delirium or psychosis. The letter K stands for Kussmaul respirations, which are rapid and deep breathing. The letter A stands for abdominal pain with nausea and vomiting, and the final letter D stands for dehydration. Patients may also have fruity breath odor due to exhaled acetone. In hyperosmolar hyperglycemic state, the signs and symptoms include thirst, polyuria, lethargy, focal neurologic deficits, and seizures. The laboratory findings in diabetic ketoacidosis include hyperglycemia, increased hydrogen ion concentration, decreased bicarbonate concentration, and an anion gap metabolic acidosis. Urine and blood ketone levels are increased, and leukocytosis may be present. Serum potassium may be normal or increased, but total body potassium is depleted due to a shift of potassium from inside the cells to outside the cells caused by lack of insulin and acidosis. Osmotic diuresis further increases potassium loss in urine, worsening total body potassium depletion. The laboratory findings in hyperosmolar hyperglycemic state include severe hyperglycemia, often greater than 600 milligrams per deciliter, increased serum osmolality above 320 milliosmoles per kilogram, a normal pH without acidosis, and absence of ketones. Serum potassium may be normal or increased, but intracellular potassium is decreased. The complications of diabetic ketoacidosis include life-threatening mucormycosis, cerebral edema, and cardiac arrhythmias. Hyperosmolar hyperglycemic state can progress to coma and death if untreated. The treatment for both conditions includes intravenous fluids, intravenous insulin, and potassium supplementation to replete intracellular stores. Glucose may also be required to prevent hypoglycemia from insulin therapy. Hypoglycemia and diabetes mellitus. Hypoglycemia usually occurs in patients who are treated with insulin or insulin secretagogues, such as sulfonylureas and meglitinides. It is often seen in the setting of high-dose treatment, inadequate food intake, or exercise. The neurogenic, also called autonomic, symptoms include diaphoresis, which is excessive sweating, tachycardia, which is increased heart rate, tremor, anxiety, and hunger. These symptoms allow perception of low glucose and are referred to as hypoglycemia awareness. The neuroglycopenic symptoms result from insufficient glucose supply to the central nervous system. They include altered mental status, seizures, and even death. These may sometimes occur in the absence of preceding neurogenic symptoms in patients who have an attenuated autonomic response, such as those using beta blockers. This is called hypoglycemia unawareness. Treatment includes giving simple carbohydrates, such as glucose tablets or fruit juice, intramuscular glucagon, or intravenous dextrose. Cushing's syndrome. Cushing's syndrome refers to the clinical state caused by excess cortisol from a variety of causes. The etiology includes exogenous glucocorticoid use, which lead to adrenocorticotropic hormone, or ACTH, suppression and bilateral adrenal atrophy. This is the most common cause. Other causes include primary adrenal adenoma, adrenal hyperplasia, or adrenal carcinoma. In these cases, ACTH levels are decreased, leading to atrophy of the uninvolved adrenal gland. Another important cause is an ACTH secreting pituitary adenoma, which is called Cushing disease or paraneoplastic ACTH secretion, as in small cell lung cancer or bronchial carcinoids. These lead to bilateral adrenal hyperplasia. Cushing disease is responsible for the majority of endogenous cases of Cushing syndrome. The findings in Cushing syndrome include metabolic syndrome with hypertension, hyperglycemia, and hyperlipidemia. There is truncal obesity with wasting of the extremities, a round face known as moon facies, and a dorsocervical fat pad called a buffalo hump. Patients may also develop osteoporosis, depression, anxiety, irritability, facial plethora, androgen excess such as acne and hirsutism, cataracts, immunosuppression, easy bruising, and skin changes such as thinning, striae, and hyperpigmentation. The diagnosis begins with screening tests, which include measurement of free cortisol in a 24-hour urine collection, measurement of late-night salivary cortisol, and the overnight low-dose dexamethasone suppression test, which shows no suppression in patients with Cushing's syndrome. If these tests are abnormal, the next step is to measure serum ACTH levels. If ACTH is suppressed, this suggests an ACTH-independent cause, such as exogenous glucocorticoid use or an adrenal tumor. In such cases, adrenal computed tomography should be performed to confirm the diagnosis. If ACTH is elevated, the patient has ACTH-dependent Cushing's syndrome. To distinguish between Cushing disease and ectopic ACTH secretion, a high-dose dexamethasone suppression test or corticotropin, releasing hormone stimulation test, is used. In Cushing disease, cortisol and ACTH levels suppress with high-dose dexamethasone, and ACTH increases with corticotropin, releasing hormone stimulation. In ectopic ACTH secretion, such as from a tumor, there is no suppression with high-dose dexamethasone and no increase in ACTH with corticotropin, releasing hormone stimulation. Imaging with magnetic resonance imaging of the pituitary or computed tomography of the chest, abdomen, or pelvis is used to identify the source of the tumor. Adrenal insufficiency. Adrenal insufficiency is the inability of the adrenal glands to generate enough glucocorticoids, with or without mineralocorticoids, to meet the needs of the body. It could be acute or chronic. Symptoms include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, gastrointestinal disturbances, and cravings for sugar and or salt. The treatment is glucocorticoid replacement, with or without mineralocorticoid replacement. Primary adrenal insufficiency. In primary adrenal insufficiency, the adrenal gland itself is not functioning properly. This results in decreased cortisol and decreased aldosterone, which leads to hypotension due to hyponatremic volume contraction, hyperkalemia, and metabolic acidosis. Patients develop hyperpigmentation of the skin and mucosa, especially at pressure areas and in the buccal mucosa. This occurs because decreased cortisol reduces the negative feedback effect on the pituitary gland, leading to increased production of pro-opiomelanocortin derivatives, which include beta-endorphin, adrenocorticotropic hormone, also called ACTH, and melanocyte, stimulating hormone, also called MSH. Increased melanocyte, stimulating hormone promotes melanin synthesis, resulting in skin and mucosal pigmentation. Chronic primary adrenal insufficiency is called Addison disease. It is caused by adrenal atrophy or destruction. In high-income countries, the most common cause is autoimmune adrenalitis, while in low-income countries the most common cause is tuberculosis. Secondary and tertiary adrenal insufficiency. Secondary adrenal insufficiency is due to decreased pituitary secretion of adrenocorticotropic hormone, while tertiary adrenal insufficiency is due to decreased hypothalamic secretion of corticotropin, releasing hormone. In both secondary and tertiary adrenal insufficiency, aldosterone synthesis is preserved because the adrenal gland and the renin, angiotensin, aldosterone system remain intact. Therefore, there is no hyperkalemia. Hyperpigmentation is also not present. Secondary adrenal insufficiency is most often due to pituitary pathologies. Tertiary adrenal insufficiency most commonly results from abrupt cessation of chronic glucocorticoid therapy, which suppresses the hypothalamic-pituitary adrenal axis. Acute adrenal insufficiency. Acute adrenal insufficiency is also called adrenal crisis or Addisonian crisis. It is often precipitated by acute stressors, such as infection, which increase glucocorticoid requirements in patients with pre-existing adrenal insufficiency or those on glucocorticoid therapy. It may present with acute abdominal pain, nausea, vomiting, altered mental status, and shock. Waterhouse-Friderichsen syndrome is an important cause. It is bilateral adrenal hemorrhage occurring in the setting of sepsis, often due to meningococcemia, leading to acute primary adrenal insufficiency. Evaluation of suspected adrenal insufficiency. The first step is to check the morning cortisol level or perform an adrenocorticotropic hormone stimulation test. A low morning cortisol level or a low peak cortisol response on stimulation testing suggests adrenal insufficiency. The next step is to measure a random serum adrenocorticotropic hormone level. If adrenocorticotropic hormone is decreased or inappropriately normal, this indicates secondary or tertiary adrenal insufficiency. If adrenocorticotropic hormone is elevated, this indicates primary adrenal insufficiency. Hyperaldosteronism. Hyperaldosteronism is the increased secretion of aldosterone from the adrenal gland. The clinical features include hypertension, low or normal potassium levels, and metabolic alkalosis. Primary hyperaldosteronism does not directly cause edema because of the aldosterone escape mechanism. However, in certain secondary causes of hyperaldosteronism, such as heart failure, the aldosterone escape mechanism is impaired, which leads to worsening of edema. Primary hyperaldosteronism. Primary hyperaldosteronism is seen in patients with bilateral adrenal hyperplasia or adrenal adenoma, also called Conn syndrome. In this condition, aldosterone is increased while renin is decreased. This leads to treatment-resistant hypertension. Secondary hyperaldosteronism. Secondary hyperaldosteronism is seen in patients with renovascular hypertension, juxtaglomerular cell tumors that produce renin, and in patients with edema, such as those with cirrhosis, heart failure, or nephrotic syndrome. In this condition, both aldosterone and renin are increased. Neuroendocrine tumors. Neuroendocrine tumors are a heterogeneous group of neoplasms that originate from neuroendocrine cells. These cells have traits similar to both nerve cells and hormone-producing cells. Most neuroendocrine tumors occur in the gastrointestinal system, such as carcinoid tumors or gastrinomas, in the pancreas, such as insulinoma and glucagonoma, and in the lungs, such as small cell carcinoma. They may also occur in the thyroid gland, such as medullary carcinoma, and in the adrenal glands, such as pheochromocytoma. Neuroendocrine cells, such as pancreatic beta cells and enterochromaffin cells, share a common biological function through amine precursor uptake decarboxylase, also called APUD, despite differences in embryologic origin, anatomic location, and secretory products. Examples of secretory products include chromogranin, neuron-specific enolase, synaptophysin, serotonin, histamine, and calcitonin. Treatment includes surgical resection and somatostatin analogs. Neuroblastoma. Neuroblastoma is the most common solid extracranial tumor in children, typically less than 4 years old. It usually arises in the adrenal medulla, but may occur anywhere along the sympathetic chain. Neuroblastoma originates from neural crest cells. The most common presentation is abdominal distension with a firm, irregular mass that can cross the midline. This is in contrast to Wilms tumor, which is usually smooth and unilateral. Patients with neuroblastoma are less likely to develop hypertension than patients with pheochromocytoma, as neuroblastoma is usually normotensive. Another presentation is opsoclonus myoclonus syndrome, also known as dancing eyes, dancing feet. Laboratory findings include increased levels of homovanillic acid and vanillomandelic acid, which are catecholamine metabolites, in the urine. Histology shows homerite rosettes, which are neuroblasts surrounding a central area of neuropil. This is characteristic of both neuroblastoma and medulloblastoma. Neuroblastoma tumors are also positive for bombesin and neuron-specific enolase. They are associated with amplification of the INMYC oncogene. Pheochromocytoma. Etiology. Pheochromocytoma is the most common tumor of the adrenal medulla in adults. It is derived from chromaffin cells, which arise from neural crest cells. It is rare. This tumor may be associated with germline mutations, including neurofibromatosis type 1, von Hippel-Lindau syndrome, and RET mutations as seen in multiple endocrine neoplasia type 2A and 2B. A useful way to remember is the rule of tens. 10% are malignant. 10% are bilateral. 10% are extraadrenal, also called paragangliomas, which may occur in sites such as the bladder wall or the organ of Zuckerkandl. 10% may calcify. 10% occur in children. Symptoms. Most pheochromocytomas secrete epinephrine, norepinephrine, and dopamine, which can cause episodic hypertension. Some may also secrete erythropoietin, leading to polycythemia. Symptoms usually occur in spells, meaning they relapse and remit. The classic episodic hyperadrenergic symptoms are remembered by the 5 Ps. Pressure, meaning high blood pressure. Pain, usually in the form of headache. Perspiration, meaning sweating. Palpitations, which are rapid heartbeat or tachycardia. Pallor, meaning paleness. Findings. Laboratory findings include increased catecholamines and their metabolites, such as metanephrines, homovanillic acid, and vanillomandelic acid, in both urine and plasma. Episodic hyperglycemia may also occur as an uncommon finding. On histology, the tumor cells are positive for chromogranin, synaptophysin, and neuron-specific enolase. Treatment. Treatment involves irreversible alpha-adrenergic antagonists, such as phenoxybenzamine, followed by beta blockers prior to surgical removal of the tumor. It is very important that alpha blockade is achieved before giving beta blockers to avoid a hypertensive crisis. Remember, alpha before beta. Phenoxybenzamine is the classic drug used for pheochromocytoma. Multiple endocrine neoplasias. All men syndromes have autosomal dominant inheritance. Think of it as the X-men are dominant over villains. Men type 1. This includes 3 main groups of tumors, often remembered as the 3 Ps. Pituitary tumors, usually prolactinomas or growth hormone secreting tumors. Pancreatic endocrine tumors, which include Zollinger-Ellison syndrome, insulinomas, vasoactive intestinal peptide tumors, and the rare glucaganomas. Parathyroid adenomas. MEN type 1 is associated with mutations in the MEN1 gene, which is a tumor suppressor gene located on chromosome 11. This gene codes for a protein called menin. Other findings can include angiofibromas, collagenomas, and meningiomas. MEN type 2A. This includes parathyroid hyperplasia. Medullary thyroid carcinoma, which is a neoplasm of the parafollicular C cells that secrete calcitonin. Because of the high risk, prophylactic thyroidectomy is required. Pheochromocytoma, which secretes catecholamines. MEN type 2A is associated with mutations in the RET proto-oncogene, which codes for a receptor tyrosine kinase located on chromosome 10. MEN type 2B. This includes medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas, also called oral or intestinal ganglioneuromatosis. It is often associated with a marfanoid body habitus. MEN type 2B is also caused by mutations in the RET gene. Pancreatic islet cell tumors. Insulinoma. This is a tumor of pancreatic beta cells that causes overproduction of insulin, leading to hypoglycemia. The classic finding is Whipple's triad. This includes low blood glucose, symptoms of hypoglycemia, such as lethargy, fainting, or double vision, and resolution of these symptoms once plasma glucose levels normalize. In symptomatic patients, blood glucose is low and C-peptide levels are elevated, which helps distinguish it from exogenous insulin use. About 10% of cases are associated with MEN type 1 syndrome. Treatment is surgical resection. Glucagonoma. This is a tumor of pancreatic alpha cells that produces excessive glucagon. It presents with the 6 Ds: dermatitis, specifically necrolytic migratory erythema, diabetes with hyperglycemia, deep vein thrombosis, declining weight, depression, and diarrhea. Treatment includes octreotide and surgical resection. Somatostatinoma. This is a tumor of pancreatic delta cells with excess somatostatin production. It decreases secretion of many hormones including secretin, cholecystokinin, glucagon, insulin, gastrin, and gastric inhibitory peptide. Patients may present with diabetes or glucose intolerance, steatorrhea, gallstones, and achlorhydria. Treatment is surgical resection with somatostatin analogs such as octreotide for symptom control. Carcinoid tumors. These tumors arise from neuroendocrine cells, most commonly in the intestine or the lung. Neuroendocrine cells secrete serotonin. Normally, serotonin is metabolized by the liver and broken down by monoamine oxidase in the lung. However, if serotonin reaches the systemic circulation, usually due to liver metastasis, the carcinoid tumor can present with carcinoid syndrome. This syndrome is characterized by episodic flushing, diarrhea, wheezing, and right-sided valvular heart disease, such as tricuspid regurgitation and pulmonic stenosis. Urinary excretion of 5-hydroxyindoleacetic acid is increased. Excess serotonin production can deplete tryptophan stores, leading to niacin deficiency and pellagra. On histology, carcinoid tumors show rosettes, and they stain positive for chromogranin A and synaptophysin. Diagnosis is made by elevated 24-hour urinary 5-hydroxyindolacetic acid. Octreotide scintigraphy is used for tumor localization and staging. Treatment includes surgical resection, a somatostatin analog such as octreotide, or a tryptophan hydroxylase inhibitor such as telotristat for symptom control. A useful way to remember carcinoid tumors is the rule of thirds. 1/3 metastasize, 1/3 present with a second malignancy, and 1/3 are multiple. Zollinger-Ellison syndrome. This syndrome is caused by gastrin-secreting tumors called gastrinomas, which are usually located in the duodenum or pancreas. It presents with single or multiple recurrent ulcers in the duodenum or jejunum that are often resistant to proton pump inhibitors. The excess acid also inactivates pancreatic enzymes in the small bowel, causing malabsorption. Symptoms include abdominal pain, heartburn, diarrhea or steatorrhea, and weight loss. A positive secretin stimulation test is diagnostic, where gastrin levels rise after secretin administration. Normally, secretin inhibits gastrin release. These tumors stain positive for chromogranin A and may be associated with MEN type 1. Endocrine pharmacology, diabetes mellitus therapy. All patients with diabetes mellitus should receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment differs based on the type of diabetes and the level of glycemic control. In type 1 diabetes mellitus, the treatment is insulin replacement. In type 2 diabetes mellitus, the treatment involves oral agents such as metformin, which is the first-line therapy, non-insulin injectable drugs, or insulin replacement if required. Weight loss is particularly helpful in lowering blood glucose. In gestational diabetes mellitus, insulin replacement is used if nutrition therapy and exercise alone fail. Regular short-acting insulin is preferred in 3 conditions: diabetic ketoacidosis, given by the intravenous route, hyperkalemia, when given with glucose to prevent hypoglycemia, and stress-induced hyperglycemia. Mechanisms of antidiabetic drugs. Metformin and pioglitazone increase insulin sensitivity in adipose tissue and skeletal muscle and decrease glucose production in the liver. Sodium glucose cotransporter 2 inhibitors decrease glucose reabsorption in the kidney. Alpha-glucosidase inhibitors decrease glucose absorption in the intestine. Glucagon-like peptide 1 analogs, dipeptidyl peptidase 4 inhibitors, and amylin analogs decrease glucagon release from pancreatic alpha cells and slow gastric emptying in the stomach. Sulfonylureas meglitinides, glucagon-like peptide 1 analogs, and dipeptidyl peptidase 4 inhibitors increase insulin secretion from pancreatic beta cells. Insulin preparations. Insulin preparations work by binding to the insulin receptor, which has tyrosine kinase activity. In the liver, this increases glucose storage as glycogen. In muscle, this increases glycogen and protein synthesis. In fat, this increases triglyceride storage. At the cell membrane, this increases potassium uptake. The adverse effects include hypoglycemia, lipodystrophy, rare hypersensitivity reactions, and weight gain. The insulin preparations are divided according to their onset and duration of action. Rapid-acting insulins, with no lag time, include Lispro, Aspart, and Glulisine. Short-acting insulin is regular insulin. Intermediate-acting insulin is NPH, which stands for neutral protamine Hagedorn insulin. Long-acting insulins include Detamir and Glargine. Very long-acting insulin is D-Gludec. The following is the time action profile of insulin preparations, showing their onset, peak, and duration of activity. Rapid-acting insulins are Lispro, Aspart, and Glulisine. They have the fastest onset of action, within minutes, and a short duration, generally 3 to 4 hours. Short-acting insulin is regular insulin. It has an onset within 30 minutes, peaks around 2 to 3 hours, and lasts for about 6 to 8 hours. Intermediate-acting insulin is neutral protamine Hagedorn insulin, also called NPH. It has an onset of about 1 to 2 hours, peaks at 6 to 12 hours, and lasts for 12 to 18 hours. Long-acting insulins include Detamir and Glargine. These have a slow onset and provide a steady basal level with a duration of about 20 to 24 hours. Very long-acting insulin is D-Gludec. It has the longest duration of action, lasting more than 24 hours, providing a very stable basal insulin effect. Diabetes mellitus therapy continued. The following are the main drug classes used in the management of diabetes mellitus, along with their mechanisms and adverse effects. Metformin. Metformin increases insulin sensitivity. It works by inhibiting the mitochondrial enzyme glycerol 3-phosphate dehydrogenase. This leads to inhibition of hepatic gluconeogenesis and inhibition of the action of glucagon. Metformin also increases glycolysis and increases peripheral glucose uptake, thereby improving insulin sensitivity. Adverse effects include gastrointestinal upset, lactic acidosis, especially in patients with renal insufficiency, cirrhosis, sepsis, or hypoperfusion. It may also cause vitamin B12 deficiency. A common and often desired effect is weight loss. Pioglitazone. Pioglitazone also increases insulin sensitivity. It works by activating peroxisome proliferator activated receptor gamma, which is a nuclear receptor. This activation increases insulin sensitivity and increases the levels of adiponectin. It regulates glucose metabolism and fatty acid storage. Adverse effects include weight gain, edema, an increased risk of heart failure, and an increased risk of fractures. Pioglitazone also has a delayed onset of action that takes several weeks. Sulfonylureas. Sulfonylureas increase insulin secretion. First-generation sulfonylureas include chlorpropamide and tolbutamide. Second-generation sulfonylureas include glipizide and glyburide. These drugs work by closing potassium channels in the pancreatic beta cell membrane, which causes the cell to depolarize. This leads to calcium influx and subsequent insulin release. Adverse effects include a disulfiram-like reaction with first-generation sulfonylureas, though these are rarely used. More common adverse effects are hypoglycemia, which has increased risk in patients with renal insufficiency and weight gain. Meglitinides. Meglitinides, such as nataglinide and repaglinide, have a similar mechanism. They increase insulin secretion by closing potassium channels in pancreatic beta cells, leading to calcium influx and insulin release. Adverse effects include hypoglycemia and weight gain. Glucagon-like peptide 1 analogs. These include exenatide, liraglutide, and semaglutide. They increase glucose-induced insulin secretion by decreasing glucagon release, slowing gastric emptying, and increasing glucose-dependent insulin release. They also increase satiety, which is often desired. Adverse effects include nausea, vomiting, and pancreatitis. They are also associated with weight loss, which is often desired. Dipeptidyl peptidase 4 inhibitors. These include linagliptin, saxagliptin, and sitagliptin. They inhibit the enzyme dipeptidyl peptidase 4, which normally deactivates glucagon-like peptide 1. As a result, they decrease glucagon release, slow gastric emptying, and increase glucose-dependent insulin release. They also increase satiety, which is often desired. Adverse effects include respiratory infections, urinary tract infections, and they are generally weight neutral. Sodium glucose cotransporter 2 inhibitors. These include canagliflozin, dapagliflozin, and empagliflozin. They decrease glucose absorption by blocking reabsorption of glucose in the proximal convoluted tubule, leading to glucose in the urine. They also cause natriuresis and osmotic diuresis, resulting in decreased blood glucose, decreased serum sodium, decreased extracellular fluid volume, and decreased blood pressure. Adverse effects include glucosuria, which can predispose to urinary tract infections and vulvovaginal candidiasis, dehydration that can cause orthostatic hypotension, and weight loss. A helpful memory aid is glucose flows in the urine. These drugs should be used with caution in patients with renal insufficiency, as their efficacy decreases with low glomerular filtration rate. Alpha-glucosidase inhibitors. These include acarbose and miglitol. They decrease glucose absorption by inhibiting intestinal brush border alpha-glucosidases. This delays carbohydrate hydrolysis and glucose absorption, leading to decreased postprandial hyperglycemia. Adverse effects include gastrointestinal upset and bloating. They are not recommended in patients with renal insufficiency. Amylin analogs. An example is pramlintide. These decrease glucagon release and slow gastric emptying. They also increase satiety, which is often desired. Adverse effects include hypoglycemia and nausea. Thionamides. The two main thionamides are propylthiouracil and methimazole. Mechanism. These drugs block the enzyme thyroid peroxidase. This inhibits the oxidation of iodide, as well as the organification and coupling of iodine, ultimately inhibiting thyroid hormone synthesis. In addition, propylthiouracil also blocks 5'-deiodinase, which decreases the peripheral conversion of thyroxine, or T4, to triiodothyronine, or T3. Clinical use. Thionamides are used in hyperthyroidism. Propylthiouracil is preferred in the first trimester of pregnancy due to the teratogenicity of methimazole. Methimazole is used in the second and third trimesters due to the risk of propylthiouracil-induced hepatotoxicity. Thionamides are not used to treat Graves' ophthalmopathy, which is instead treated with glucocorticoids. Adverse effects. These include skin rash, agranulocytosis, which is rare, aplastic anemia, and hepatotoxicity. Propylthiouracil use has also been associated with ANCA-positive vasculitis. Methimazole may act as a teratogen and has been linked to aplasia cutis. Levothyroxine and liothyronine. Mechanism. These are hormone replacement therapies. Levothyroxine is synthetic thyroxine, or T4, while liothyronine is synthetic triiodothyronine, or T3. An easy way to remember this is that levo has 4 letters corresponding to T4, and leo has 3 letters corresponding to T3. Absorption of levothyroxine can be reduced if taken with antacids, while acid resins or ferrous sulfate. Clinical use. These drugs are used in hypothyroidism and in mixedema. They may sometimes be misused for weight loss. Exogenous hyperthyroidism from excessive thyroid hormone replacement can be distinguished from endogenous hyperthyroidism using a combination of thyroid-stimulating hormone receptor antibodies, radioactive iodine uptake testing, or ultrasound measurement of thyroid blood flow. Adverse effects. These include tachycardia, heat intolerance, tremors, and arrhythmias. Hypothalamic and pituitary drugs. Conivaptan and tolvaptan. These are vasopressin or antidiuretic hormone antagonists. They are used in the treatment of syndrome of inappropriate antidiuretic hormone secretion, also called SIADH, by blocking the action of ADH at the V2 receptor. Dimeclocycline. This is also an ADH antagonist and is a tetracycline antibiotic. It is used in the treatment of SIAD because it interferes with ADH signaling. Desmopressin. This is an ADH analog that is used in central diabetes insipidus, in von Willebrand disease, in sleep enuresis, and in hemophilia. Growth hormone. Growth hormone is used in growth hormone deficiency and in Turner syndrome. Oxytocin. Oxytocin is used to induce labor by stimulating uterine contractions, and it is also used to control uterine hemorrhage. Octreotide. Octreotide is a somatostatin analog. It is used in acromegaly, in carcinoid syndrome, in gastronoma, in glucagonoma, and in the management of esophageal varices. Fludrocortisone. Mechanism. Fludrocortisone is a synthetic analog of aldosterone that also has glucocorticoid effects. A useful way to remember this is that fludrocortisone helps retain fluid. Clinical use. It is used as mineralocorticoid replacement in primary adrenal insufficiency. Adverse effects. These are similar to glucocorticoid adverse effects and also include edema, exacerbation of heart failure, and hyperpigmentation. Cinacalcet. Mechanism. Cinacalcet sensitizes the calcium-sensing receptor, also called CSR, in the parathyroid gland to circulating calcium. This decreases parathyroid hormone secretion. The correct pronunciation is cinacalcet. Clinical use. It is used in secondary hyperparathyroidism in patients with chronic kidney disease receiving hemodialysis. It is also used in hypercalcemia due to primary hyperparathyroidism when parathyroidectomy fails, and it can be used in parathyroid carcinoma. Adverse effects. The main adverse effect is hypocalcemia. Sevelamer. Mechanism. Sevelamer is a non-absorbable phosphate binder. It prevents phosphate absorption from the gastrointestinal tract. Clinical use. It is used in hyperphosphatemia associated with chronic kidney disease. Adverse effects. These include hypophosphatemia and gastrointestinal upset. Cation exchange resins. Examples include pathyromer, sodium polystyrene sulfonate, and zirconium cyclosilicate. Mechanism. These agents bind potassium in the colon in exchange for other cations such as sodium or calcium. This leads to increased excretion of potassium in the feces. Clinical use. They are used in the management of hyperkalemia. Adverse effects. These include hypokalemia and gastrointestinal upset.